We welcome you all for our dynamic and vibrant platform. Yes, it's panel discussion with a distinguished moderator and also panelist. We take pride to welcome Dr. Balaji Arumugam sir, moderator for the session, and we also welcome panelist Dr. Major G. Shivkumar sir, Dr. Vijetha ma'am, Dr. Anjana ma'am, and Dr. S. Gopinath sir to the dais to feast us with their sparkling and expertise talk. I request Dr. Sangeeta ma'am, Vice Principal, to introduce the moderator, sir. It's my pleasure to introduce Dr. Balaji Arumugam, who is Professor and Head of the Department of Community Medicine in Arunai Medical College. He is an external resource faculty at NMC Nodal Center, CMC Vellore.
Sure.
He is also MEU Coordinator and IRC Co-Coordinator. He's also General Secretary of TATCOM. He has got 16 years of teaching experience with guiding about 100 plus research projects. Add on to it, he has got 120 publications and 12 in H index. He is a reviewer in leading journals. He has got more than 10 awards. In that includes Best Doctor Award too. He is author for more than 7 books. Over to you, Balaji. I now request Dr. Gauri ma'am, Vice Principal, Vellore Medical College, to introduce our panelists, Dr. Major G. Shivkumar sir and Anjana ma'am.
Hello. So I'm really happy to introduce panelists for today's panel discussion. Dr. Anjana. Madam is Professor and HOD, Department of Anatomy from Govt Chengalpat Medical College with a teaching experience of more than 12 years and with a research experience of 12 years. Our next panelist is Dr. Major G. Shivkumar sir. He's an associate professor in the Department of General Medicine from Govt Medical College, Nagapattinam, with almost 25 years of experience and 14 years of teaching experience with more than 27 publications with a H index of 6. Thank you.
I now welcome Dr. Appadurai Rajendran sir, HOD, Professor Dentistry, Vellore Medical College, to introduce our panelist.
It's my pleasure and privilege to introduce the other panel members. Madam Vijetha Shenoy from Manipal, Associate Professor of Biochemistry, with 12 years of teaching and research experience, with more than 50 publications and an H index of 10. The next in the panel is Professor S. Gopinathan sir, Professor of Pediatrics from Government Mohan Kumaramangalam Medical College, with more than 14 years of teaching experience and research experience. Your discussions will enrich the audience. Over to you, sir. Hello. Hello. Am I audible? Good evening to everyone. At the outset, I would like to thank this our organizing team, DEEPAM Medcon. Special thanks to our Dr. Priscilla ma'am for identifying me as sir. Sir, hopefully we'll do the session very nicely for moderating this particular session. Dr. Priscilla ma'am, thank you, and our Dr. Sangeeta ma'am, Vice Principal, and none other than our Dr. Kribagaran for connecting me with this particular team. And I thank all the 4 experts, our Dr. Vijetha ma'am, Major Shivkumar sir. It's been more than 15, 16 years. I'm seeing Major Shivkumar sir. Me and Dr. Shivkumar sir worked in a project. Anjana ma'am, we First, we got introduced in Meded Connect. Appada first meet pannom. Nice to meet you, ma'am. Gopinathan sir, first time I'm meeting him. Thank you so much. So we'll straight away go into the panel discussion, and the panel discussion I'm planning for 3 rounds. We'll try to make maybe as short as possible, right? Because for running short of time. So round 1, as we know, ACME, we talk about 3 important things about reflection layer, right? What happened? So what and what next? So what happened is will be on round 1, and then round 2 you have so what and what next, right? And round 1, I think, our 4 experts is on. First one, our Dr. Vijetha ma'am will be a CBME implementation and faculty development expert. Major sir, sir will be mainly focusing on assessment, and Anjana ma'am will be focusing on integration mainly, and Gopinathan sir will be focusing on AdCom and professionalism. So ரொம்ப overlap இருக்கக்கூடாதுனால we wanted to have a expertise like this, because medical education அப்படின்னும் போது everyone in the last 6-7 years cursing the NMC, and at the same time past year we have spoken about a lot of things about NMC, the CBME, நிறைய பேசியிருக்கோம். And of course in the last 2 days, நேத்து இன்னைக்கு morning 1.5 hours, last 1.5 days, already a lot of panel discussions have happened on the floor and off the floor, right? So specifically, I would like to start the discussion on 4 important major questions, right from our Dr. Vijetha ma'am. I would like to initiate the discussion mainly on CBME implementation process, ma'am. See, what is your particular opinion or your perception regarding your CBME has been introduced in around 2019, isn't it? So after the introduction, what really changed in your teaching? You belong to Biochemistry now, madam. So what really changed in your teaching, and what mostly remained on just paper? So can we have a discussion from yourself, your point of view, ma'am?
Thank you, sir, for that question. So this question has 2 parts. The first one is what changed, and the second one is what remained on the paper.
Yes.
So first I will focus on what changed. So when CBME was introduced in the year 2019, the first and foremost thing that changed is the way we started teaching to the student. The teaching changed from teacher-centered to the student-centered. The second thing was about implementation of early clinical exposure. So for the first time, the student visited the wards, they visited the community settings, they saw the patient earlier than before. So most of the medical colleges, they implemented EC for the first time in 2019 after the implementation of CBME. And coming to the third point, that is about the structured AdCom module. So before CBME, it was hidden in the curriculum, but after the CBME, there was a proper structured framework was given for the AdCom module, and it was a longitudinal program. And the other things that we implemented was incorporation of formative assessment. More emphasis were given for formative assessments. Then family adoption programs, where the student first time they met the families in the communities, they interacted with them, and also.
So what is
Yeah,
your, sorry for the interruption, ma'am. See, my question is mainly a little bit more focused on, so do you think that your way of teaching towards the students, has it changed just because that the CBME has implemented certain teaching learning methods, and you would have learned a lot of things in BCME workshop and ACME or whatever? So do you think that your way of teaching has really changed after the CBME, or it's
Yes,
same?
it has changed after the CBME, because in that before we were doing just the didactic lecture, but nowadays we are introducing the case, we are doing the assessment at the end of the lecture class itself. And in the small group teaching, we are trying to implement some of the newer teaching learning methods. So these were something that changed after the CBME.
So definitely there is a change in shift of teaching learning
Yes.
methods.
And what remained, to answer the second part of the question, what remained on the paper is, one is logbook. Why I feel is we were just signing the logbook just for the sake of completion, meeting the requirements. We were not giving the meaningful feedback to the students. The second thing is about self-directed learning. As yesterday, Dr. Praveen Iyer sir said this, that he showed one slide where he showed us how to take self-directed learning. There were 2 contact sessions, and in between one intervening session was there. But what we did was we just gave a simple topic and simple questions, asked the student to write the answer for them, and we assessed them. Actually, the role of a teacher as a facilitator was not there in SDL. Even we shifted our teaching to student centered, but our assessment remained the traditional method. Our assessment were focusing only for the cognitive knowledge, not
Okay,
assessing
so
the
let's
other
talk a
levels.
little bit more about this assessment. We'll try to get the opinion from our assessment expert. Sir, what is your opinion, sir? What has happened really because of the CBME? Do you think that the assessment, way of assessment has changed? Maybe your opinion on before CBME or after CBME?
Regarding assessments, a very important aspect, like definitely there has been a change in the assessment pattern, like as what Modern said, pre-CBME, post-CBME. But I wouldn't say it is complete already. So the CBME curriculum wants us to assess the students in all the three domains: cognitive domain, affective domain, psychomotor domain. Pre-CBME, there was somewhat okay assessment of cognitive domain, subjective assessment of psychomotor domain, and absolutely no assessment of affective domain. But with the advent of CBME, cognitive domain assessment has become more scientific. Now we resort to more higher order thinking skills. We employ objective methods, MCQs, structured essays, structured short notes. That way, higher order thinking skills are being assessed. Problem-based questions, case vignettes.
So you
all
mean
this.
to say that assessment has become more of organized and structured,
Yes, sir.
isn't
Definitely.
it? Hmm.
And the psychomotor skills also, earlier on when examiners used to come, they used to have prefixed ideas. If the student does plantar extensor, he's fit to pass. If he releases the knee jerk, he's fit to pass. But the breakup of that, the rubrics, all the checklist was not there. Now with OSCEs, it has also become more and more objective, and the student defines the steps and he does it properly. So psychomotor skills also to a certain extent we have.
Apart from OSCEs, do you implement any other assessment methods, especially after the implementation of the CBME?
Yes, sir. We do
Not in paper, maybe as a formative assessment in your department or
Yes, sir.
any other.
Longitudinal assessment, that is formative assessment. It is not just the usual end of posting or end of term summative assessment. While teaching bedside also, we give feedbacks, demonstrate, we deconstruct the DOPES method. We also do the mini CSX examinations. Those are also being done as part of assessment schedule during formative assessment. And we give structured feedbacks also. In another way, you have prompted me rightly. Pre-CBME, it was only focusing on marks and summative assessment. Now we are focusing more on longitudinal and formative assessment so that students learn as they progress.
So we give more importance to formative assessment, and you're also implementing certain latest introduction of these dopes and other things you are able to perform. Fantastic. Nice to know. Right. Let us hear from integration expert. What is your opinion, madam? I would like to get it from you, both integration as well as ECE, because you are from basic sciences. I would like to hear more about this ECE and as well as your integration part.
See,
Maybe you can talk about both vertical or horizontal water.
so true,
Yes.
sir. So as far as CBME is concerned, there's definitely a positive shift made because of CBME towards the structured alignment in the first place, across the phases in the horizontal, the same phase,
Yes.
and more so with the integration part, both horizontal and vertical has been made mandatory now.
Yes.
And NMC in their module, they have prescribed 6 disease modules. And now our job in our institution is to have a structured session planning to integrate it so thoughtfully that we don't extend our sessions, but we try to incorporate those sessions within the common lectures planned by the faculty.
Oh, that's fantastic, madam. So what is
And-
your, when you plan those integrated sessions, do you have do you feel like it's a cakewalk for you, maybe as a team, or what is your
So there is an
resistance from
answer
other
in the
faculties?
question itself. It definitely is not a cakewalk because there are time constraints, and more so with the varying levels of faculty preparedness and the motivation level of faculty as well. We have to allocate time in preparing the modules because we are supposed to identify the overlaps to prevent redundancy in the first place, and that is the main reason. And more than that, try to create sessions such that there are linker cases common to those modules,
Yes.
and you
take that case and implement it in every lecture, but you talk about your subject speciality and the relevance to it alone in your face.
So have you practiced any sessions like inviting the clinicians, super specialists, especially for ECE sessions or integrated sessions?
Sir, ECE, I have to say it is definitely a boon in that way because, it has been so relevant now. ECE not just incorporates the academic part.
Yes.
At DEEPAM, it is so relevant because how the timing of the sessions is so rightly well placed. Humanities is an important component of ECE as well. And that component has never been taught as a separate objective, but they have framed as an individual objective for ECEs, the humanities part as
Fantastic.
well.
So you have planned such a sessions in
Yes, sir. But one aspect that we notice is a special constraint is when we can have a structured reflection for the EC, it would be more effective, sir.
Fantastic.
Yeah.
Sir, now let's hear something from AdCom and professionalism, sir. So AdCom வந்து என்ன கேட்டீங்கன்னா in 2013 when I got exposed to medical education first time. அப்பதான் first I heard the word AdCom, attitude and ethics and communication. அப்போ E component கூட இல்ல when it was introduced. Then later on it came with the AdCom. Then after 2019 introduction, some 1 or 2 years later only we received that AdCom module, not immediately along with 2019 CBME module, right? So what is your perception regarding this before CBME and after CBME, especially focusing towards teaching on AdCom and professionalism?
Thank you, sir. Before introduction of CBME, AdCom used to be like passing on instructions from seniors to the learners, like come with your hair tight, do not wear jasmine, respect to the cadaver, wear shoes, tuck in shirts, kempt hair, shaven beard. These were the instructions. Do not giggle in the ward, do not make jokes. We did not know that it was something related to AdCom. It was thought of as good behavior and we followed it. But after introduction of the AdCom module, we have started following the AdCom module, and the AdCom module clearly gives modules for each phase. Phase 1 has 5 modules, phase 2 has 8 modules.
Yes, sir. We have so many modules for so many
Modules are
years.
there.
As a pediatrician, you are a pediatrician, sir. So as a pediatrician, like especially the modules which is coming for this pre-final and final year.
Yes, sir.
So what is your, opinion regarding the implementation during these phases? Because phase 1 and phase 2, I think even in our college, we are finding little bit of difficulty in implementing AdCom in further years. Phase 1 and phase 2 till even phase 3 also we were able to, this is my personal opinion. I would like to get the opinion from you regarding practicing AdCom and professionalism module per se implementation, especially during the final years.
Yes, sir. For our final year, for phase 3 students, the module is regarding communication. So we planned in such a way that we have general clinics once in a month. So during one general clinics, we take a chronic disease like nephrotic or thalassemia. We allot a session for AdCom in that, where there will be a short lecture along as to how the news has to be told to the patient, or how we have to explain the treatment and how he has to come for follow-up. Everything will be a short lecture. And then
do you adapt, sorry for the interruption, sir. Do you adapt any other teaching learning methods apart
Yes.
from lectures and all, especially for implementing AdCom?
role play we do, sir.
Role play most
Role
of the
play we do, and then we in the next session we split them into batches, and one batch will assess, and another batch will do the role play. We
Okay.
follow the Kalamazoo principle checklist, and we give the feedback also in the next session.
So you give the feedback also, you get the reflections from the students also. So
Yes.
somewhere we have moved from 2019, we have implemented this teaching learning methods. We all got trained from various nodal centers. We were able to do some structured assessment methods and fantastic integrated sessions, and also including AdComs. And now round 2, gradually little bit, I just wanted to go a little bit in depth further. This place I really wanted to ask about. See, we have done certain things. We have moved from 2019 to this place to certain things, especially for implementation process for expert. Regarding the CBME implementation process, I would like to ask on round 2, especially focusing on what is the impact of this CBME implementation on students, especially faculties. Maybe we need to find out this impact among the patients and patient care, it needs more time actually. So what do you think that the impact, madam? So how do faculty struggle with implementation of CBME, and what happens? Suppose if you feel like NMC is always acting like a rule book, you have to follow this rule. That's it. No questions of asking feedback. See, we are giving the feedbacks to the students. But do you think that the NMC listening to our rule book, I mean their rule book feedbacks, madam? Do you think that our feedbacks is being listened by the NMC? What is your opinion regarding the implementation, please?
So when CBME was implemented, there were so many challenges. Faculty faced so many difficulty, and that directly impacted the student learning and assessment also. So we can group these difficulties in under 4 headings. One is at the institutional level, where there was lack of skill labs and the resources for conducting the small group teaching. The second one is about the training. Faculty were given only one-time training, and they were just given so many so many new techniques, but they were not equipped to do newer teaching learning methods. And the third one is regarding the faculty, because even though they were trained, the transformation was still incomplete. They were trained in CBME how to take the classes, how to incorporate the newer teaching methods, but the transformation was still incomplete. And the final one is about documentation, because in CBME the faculty felt it is too much of documentation and paperwork. They were doing teaching, they were doing assessment, they were documenting. Everything is happening simultaneously. They perceived CBME as a heavy paperwork.
Exactly,
So-
madam. So I would like to share my point of view, especially regarding documentation. This is not exactly related to CBME implementation document. This is regarding the logbook documentation. See, I belong to community medicine, right? Previously, during my UG period, we know, sir, we have only one logbook. Whatever practical logbook. Now we have 4, 5 logbooks, including FAP logbook, right from first year to final year. And especially our MGR University, other NMC also recommends we need to write the reflection for each and every student, 150 to 250 students. So what is your opinion on this, madam, especially?
Same thing, sir. But because there is too much of documentations, what happened was the feedbacks, the meaningful feedback were limited. They just did the signature on the logbook for the completion sake to meeting the compliance requirement. So they did everything for the compliance sake, not for real teaching and assessment.
Thank you so much, madam. Anything else you want to add on this CBME implementation, especially on students and faculty? You said, madam, what do you think of that it will especially focus towards future doctors? Students, now they are students actually. So this is to Vijetha, madam, only. So what is your opinion on this, madam?
So because of faculty were focusing on the completion of the requirements, sir, the student and faculty did not have a clear idea about how to interpret those competencies and specific learning objectives. This created confusion among the students. So students reverted back into exam-oriented students. So their learnings were focused on what will be asked in the exam rather than what they should be able to do, what competency they should be able to develop. So even though we tried multiple things, I think initial period, it was more of exam oriented learning from the student side.
Yes, ma'am. Thank you. See, just to add add a point from my side, it is faculty who got confused more rather than the students. Students go assessment drives learning. Now exam pass பண்ண அவ்வளவுதான். மத்தபடி these competencies, logbook, all these stuffs are for the faculties only. Sir, now let us just hear from our major sir. Sir, what is your impact of assessment going to be on the future doctors? How do the current assessment, you said you started practicing some assessment now, sir. So how do this current assessment is going to influence their learning process in future?
As you rightly said, sir, very appropriate wording there. Assessment drives learning, sir. For example, today, if I tell my students, medicine process students, next week you are going to have an internal assessment. The first question the students ask me is, so what is the pattern? What is the pattern? How are you going to assess us? Is it going to be clinical, theory? Is it going to be MCQ? That determines his formatting of his preparation. Likewise, each and every assessment will reflect upon how he is going to prepare and how he is going to learn. And the most important impact, I would say, is feedbacks. As I earlier said, earlier there used to be only one summative assessment, pass, fail, that's all. That doesn't drive learning, it's only create anxiety. Whereas longitudinal and every frequent assessment, multiple methods, giving feedback, gives him motivation to learn, gives him, helps him in deep learning methodologies, so many advantages. And that way, definitely it will influence the for future doctors.
So do you have a separate feedback session, sir, especially on assessment? Do you have any separate feedback session on yourself, maybe from your department? Or students themselves, they were so much interested in coming and asking you the feedback regarding their assessment?
There are a segment of students, sir. They do come, but not all, sir. As you might imagine, the most interested students, they themselves come and ask, how did I do? What was the paper? Did you feel all right? Those students are moving forward. They take on the onus on themselves to learn, but the majority don't come. It is the responsibility is on us to give them feedback. And we tried implementing a research project, sir. We gave them directed deep learning sessions and then assessed them with structured MCQs and short answers.
Yes.
And the feedback we got from them was astounding. It was such an eye-opener. So earlier on, they used to, the posting, medicine posting, okay, CBS, RS, rheumatic arthritis, that's what they used to learn. But once we started this project on them, we said, you engage in deep learning, we are going to ask you concept-based questions, concept-based structure answers. And they all felt so confident at the end of the tenure of 4 weeks. They gave us such good feedback that this was something which we have not experienced so far. But definitely assessment has got a hold. How we assess?
So when you get such feedbacks, because in our department, we used to get the feedback most of the time, I used to say that by Google form.
Yes.
Because 200 to 250 students in person directly, because when they come to the clinical posting in community medicine, we get to have a communication directly because they come in a small batch, right? These feedback sessions, especially, we used to get it from Google Forms, sir. Any other method that you are adapting as an assessment regarding assessment, especially?
Yes, sir. Sir, as you said, when we are taking lectures for the whole batch, we also resort to the same, sir. Audience response system.
Yes, sir.
Group feedback, sir. When we correct their internal assessment papers, we know that all of them are making the common mistakes. So we put them as a group and ask, why did most of you make this mistake? Then they give us correct feedback. So in this book, it is written like this. Then we get the idea that all of them are following the book. That's why they're having this one. So group feedback is one of the methods we follow. And we have tried implementing one more innovative method, sir. We ask them, when we go for individual feedback, we ask them feed forward. We call them and they say, and we tell them, okay, this is your answer sheet. What do you think?
Yes.
What went wrong, or have you done well or not? So that has given a lot of, self-importance to them, and they themselves, they tell us what we want to convey.
So they understand the importance of the assessment and they do come and give you the feedback. If not the entire percentage, so to some extent they are coming, right? So let us hear from Anjana ma'am. Ma'am, I would like to ask especially this specific question. After this integration, you said that you have done integration and all. Do you think that the students are really, they are able to connect the basic sciences with the clinical sciences, madam? What is your opinion regarding this?
So of course, the students.
If you feel like there is a gap exists still, how are we going to fill it up?
So I would like to quote the example or the impact of early clinical exposure session.
Yes.
Just the hospital visits, not just the token hospital visits without any clear objectives, the proper structured sessions with clear objectives and the faculty with an intention to teach the students the basic concept. There has been a positive effect of integration upon understanding of the basic concepts and trying to apply that knowledge during clinical, when they see the patients in real time. Because now there is a shift even during our lecture classes, sir. We begin with a set induction of a case.
Okay.
There is a case-based discussion happening even during first year, sir.
So do you follow the students in the second year and third year, madam? Because you have been teaching them for ECE and making them to learn about clinical sciences. Do you have any chance to interact with definitely we will interact with our seniors, I mean our clinical side faculties and all. Do you have any chance to find out the long-term assessment, maybe a feedback or the learning experience of the students?
So technically speaking, we do not have the formal entry of students into the departments, but CBME has given us the window of electives. When initially electives was introduced and the minimum number of learners, for the first time, we just wanted to give it open-ended. We had nearly more than 50% of students opting for anatomy.
Okay.
Because they found improved correlation of this particular basic science concept in the clinical case scenario.
Okay.
So that definitely has an impact, sir. So,
right. Thank you, ma'am. So suppose if you feel like there is a huge gap between the connecting between the basic science and clinical science, do we have any solutions for that, madam, apart from clinical case scenarios or any other way of approaching the students to get it connected with the...
the problem lies with basically planning of the session. So the onus is on the faculties. We have to identify the overlaps. The AITO team, as prescribed by the NMC, the Alignment and Integration team, they have the responsibility to fix. The AITO team, they have to identify not just the gaps, but they'll have to identify the competencies related to those gaps. And the competencies must be referred to the respective departments and the respective phases as well. And that the onus is on us now, sir.
Thank you so much, ma'am. Regarding when you are giving your opinion, you spoke about the aligned integration team, AITO team, right? So to be frank, to many colleges when I've been interacting, especially I'm telling about the private sector, this alignment integration is to certain extent it is possible in first year and also phase 2 is also okay. When they come to phase 3, part 1 and part 2, this alignment integration is almost getting diluted. This is my personal opinion. People may have their opinion because many colleges, they do it in a different way. Sometimes it lacks some uniformity also. Thank you so much, ma'am.
Yes.
Now I would like to hear it from our sir, ATCOM expert, sir. Sir, what are the consequences of weak communication, especially we have been teaching the students regarding ATCOM and professionalism. So I would like to hear you, especially hear from you, focusing on how are we going to give them the community exposure or community oriented, because Spices model, we talk about community oriented teaching because we wanted to implement communication skills to the students. So how are we going to implement this process? What is exactly happening now?
Learners are now going through early clinical exposure. So they come across patients early in their course, and
somehow they are coming to know about the patients in the first year itself.
First year itself, they know about the patients, and in a guarded or in a supervised manner, they interact with the patients. That is it, sir. But once they are taken to the community, for example, in the first phase itself, in the family adoption program, they come to know about the patient in his own real setting, in his living area, what are the problems he faces and what are the common diseases. The diseases that occur, that they come across in a tertiary care hospital are totally different from the diseases that exist in the community setting. So they are exposed to that, and I could get some feedback from the first MBBS students. It was truly revealing. Student was able to say that most of the illness in the community is because of lack of health education, and it could be prevented easily rather than treated. This was a statement from the first phase student. And another student was overwhelmed when they were inviting her to their home and giving her coffee, tea, and all. And they recognizing she really felt like a doctor at that time. That was a statement by that student. So family adoption program could make a real impact.
Yes, sir. So regarding family adoption program, if you trigger that point towards me, I'll talk for hours together. Especially for first year students, family adoption program is really a wonderful opportunity. But of course, we have a lot of logistic issues taking the students for a huge batch, bigger batch. But finally, out of 150 or 200 or 250 students, when you take them to the community for FAP programs, they get a wonderful exposure. Even during our lunchtime also, we've been talking about this FAP program, especially for imparting the communication skills and also to talk about a humanistic approach and all. We need to take them to the community. That is happening in our community medicine. And I would like to, this question is for all the four experts, especially this point. I've been talking to many experts, many medical educators. Learner doctor method or a newer component which has been introduced. I don't know. I'd like to know because clinical clerkship, this otherwise called as clinical clerkship, right? ஏதோ ஒரு formula, when you go through the definition of the clinical clerkship or learner doctor method, இதெல்லாம் ஒரு ஏதோ ஒரு formula, we have been doing it. I mean, I have been doing it during evening hours. We used to go and take the cases as a part of team and all, but not under the supervision, right? So what is your opinion regarding this? Is for all four of you. I would like to definitely, because we have spoken about various newer components. So this is a learner doctor method related. I would like to especially ask to both the clinicians. So what is your opinion? What is exactly happening in learning doctor method? Were you able to implement to certain extent what is really going on? Because at the end of the day, every 3 months or 4 months, we are supposed to send a feedback to our nodal center, right? So what is really happening, sir?
To tell about what is really happening, we are in our hospital, we are not following learner doctor method clerkship to be there. But in the morning sessions, when the students come for the postings, only one student gets to interact with the patient, maybe two, for taking case.
That is quite regular happening, no? Bed
Yes, sir.
clinic patient,
They can
student
come
will interact
after
with the patient and they will get the case and then they will present it to the examiner, assessor or faculty, right? So what is your opinion, sir, Major sir?
I would again go back to your question earlier, sir. Pre-CBME, post-CBME. நீங்க சொன்ன மாதிரி, as you said appropriately, முன்னாடியோ earlier on it was happening. Now it has got a structured format that these students in this batch should come here, this space. Now the only problem here is with time and resource faculty, everything is going on well in papers. It is documented that this student has come here and seen this patient and following on the patient. But whether it has translated into actual on-ground knowledge is still a big question. In the morning when faculty comes, you cannot expect all the 7 students to undergo, we cannot post a faculty in the evening out of his working hours, ask him to supervise. So this work practically we do through postgraduates. Our junior
So undergraduates mostly, sir. In my college, I would like to share my experience. Sir. In our college, some 2-3 colleges when I was interacting, especially when I was talking about this learner doctor method as an MEU coordinator, I wanted to implement in our college, sir, because at least for the sake of sending the document as a feedback to the CMC Vellore or whatever nodal center, there was a lot of resistance from the clinicians. This is from my personal opinion. This is what is the from some of the other medical colleges. Please, sir, already we are having a lot of burdens with the patients' care and all. If you tell the students, if you post, because it is a supervised one, no, so learner doctor method is supervised one. Okay, right? So maybe at the end of round 2, after implementation, now in the last 6-7 years, we have moved a lot, we have implemented, and students have learned a lot, and students are picking up, and especially AdCom, communication, assessment, we are just moving on out, right? So now I would like to complete the panel discussion. Maybe at the end of the expert panelists, we would like to hear voices from the audience also, but at the end of all 4 experts would have final opinion. Sir, what next? For our third point, this is to our Vijetha ma'am. What next? So moving towards CBME 2.0, because that's the actual title. The title is, our title is Rethinking Medical Education for the Next Decade, 2035, right? So what is one simple change which can help the faculty? Because you are a faculty development expert. One important thing that change can help the faculty to teach CBME in a better way. And also to adding on to, I have not yet completed, madam. I'll finish up with another question also. How can the institution can support the faculty to feel more confident enough?
So one change is after each skill, after each procedure, after each case presentation, we can tell the student what went well and what can they improve upon. So this will give more motivation to the student and they know in which area they are confident in. So this does not require any extra infrastructure or does not take much of time. So if you practice this over the period, the faculty become very comfort in giving the feedback, as well as they get more and more clarity about CBME. And the other thing is we can implement one of the innovative teaching methods. Instead of taking the didactic lecture, we can introduce a task-based topics surrounding that topic. For example,
to be very specific, madam, from
Yes.
my side, I have completely known about this CBME and all these things after me becoming a resource faculty for BCME only. Okay, right. When you teach to our own faculty only, we'll learn much more.
Yes.
Yes, ma'am. Please proceed.
So we can do task-based teaching. One
Yes.
example I'll share. So in biochemistry, we teach biomedical waste management when they are in the first year. And this is very, very important in our medical profession. If something goes wrong, then everybody who are involved in the medical professions are exposed to that risk, plus including our community. So instead of just giving a content delivery, that is just the didactic PPT-based classes, we give a set of ways to the student, ask them to segregate into different color-coded bins. So
Fine.
we observe when they're performing it, and then we discuss why they have selected that particular waste. So we are just shifting just the content delivery into a task-based, the focused task-based learning. So coming
So that they can learn much better.
yeah, the retention of
becomes
this
better.
will be a longer period. They retain it for the longer period. Then coming to the institutional supports, one, the department can plan the department level faculty development program. They can share the good practices that have implemented in the CBME during their department meeting so that they can handhold and help the other faculty to also implement it. The second one is allocation of protected time for teaching and learning and assessment. Sorry, teaching and learn, because assessment, that is our role. So the conflict between this clinical service, diagnostic service, because I belong to diagnostic service, and we always say we have so many reports to certify and we can't take so much of theory classes, small group discussions. So this conflict between this diagnostic service and the teaching can be reduced or minimized. And the third one is implementation of learning management systems and digital capturing system,
Absolutely.
which will reduce the burden on the faculty for documentation. And lastly, and the main important one is recognizing and rewarding those faculty who have done innovation in teaching and learning. This will motivate the faculty.
Thank you so much. I think one fine morning we'll receive a circular from NMC that LMS is going to be mandated in another 6 months. It needs to be implemented. So even if it comes only, then we'll proceed with this thing. Thank you so much, ma'am. What is your, to add on one more point, as an MEU member and CC member, all of us, right? So as an implementation expert, what is your opinion? In spite of doing so much of, I shouldn't say this, donkey's work sometime, right? So as an MEU member or CC member, because what sort of recognition that we get actually from
Can
the
you
institute?
please repeat? I did not.
Recognition, like in spite of doing so much of MEU related work, because it is all extra departmental, isn't it? Right?
Yes, sir.
I do. So maybe this question is from my heart, I guess. Right? I mean, all the questions are from my heart only. Yes, please, madam. No, this question anyone can answer, please.
You can take.
Please, ma'am.
So there is a saying, sir, there's a saying that in our setup, sir, in general public sector workings, the one who does the work usually gets more work. The one who doesn't work gets salary. So we get more work. Somehow we feel happy with that work. That's it. It's a humanistic way of thinking of it.
Fantastic. Sir, again, the question is to you only, sir. What is the one important change that you want to implement to make CBME better by 2035? Your suggestion is?
There are so many important changes, but I'll stick to, I cannot say exactly one. I'll say two important,
yes, please. You
two important changes which I would like to bring in. The assessments which we follow are still, even though we do longitudinal assessment and formative assessment, it is still largely dependent on a summative assessment. Towards the exams, everyone gets study leave, they bunk their classes, they focus only on marks and get pass. So that system should change. Longitudinal assessment and formative assessment should be given equal importance as it is summative assessment. Multiple methods of assessment.
Be given equal importance by the faculty or by the students or by the system.
It should start from the system through the faculty to the students. So that's the way it has to follow. And multiple methods, multiple times. That's when your assessment is proper. That's when it will translate into a good student going into the community. So that is one change I want to bring about. Second, even today, even though we talk about CBME, contextual assessment is lacking, sir. Even today, as far as medicine is concerned, long case we always keep rheumatic heart disease, and we always assess CVA.
Yes.
Whereas is ground level probability of seeing a rheumatic heart disease 1 in 100 in 100 practices. You should know more about fever, poisoning. You should know about diabetes.
But still, we have those cases only in the long case for examinations.
Example. That is still not being on ground practice. That's the biggest fault. That is what contextual assessment. In what context is being assessed? You should be assessed in those cases which is likely to see in the future. So that's another change I want to bring.
Yes. So moving to our Anjana ma'am, what is your one important small change or a bigger change?
Sir,
you always aim for big, no, madam. Please.
Even though I'm an integration expert, I'm going to encroach upon his expertise, sir. Please, if you'll allow me, sir. Sir, we keep talking about integration. Have we ever moved towards integrated assessment still? We are still subject-specific assessments are carried out. Until we shift towards integrated assessments, students will keep working in, or they'll, department faculty as well, they'll keep working only in silos. So we should focus more on integrated assessment, problem-based questions rather than recall-based questions. And why not focus on the logbook entries? The logbook entries can be made more structured by asking the patient to sorry, the students to have impact on how correlation they made with the basic sciences concept. How can they apply the knowledge they have learned with relation to patient care?
Absolutely, madam. That's a fantastic idea. Integrated assessment,
Yes,
right?
sir.
So again, the biggest problem is the logistics.
Yeah, the
Create the assessment
Sir,
system, train the faculties for integrated assessment. Yes, ma'am, please.
of course, any change will always face
Absolutely.
with resistance initially, but when we start working towards it, we'll find the solution eventually.
So you would like to focus more on integrated assessment.
Hope so. So at least we can begin with logbook entries to focus more on the application of knowledge rather than just the recall based entries.
Thank you, ma'am. Thank you, ma'am. Sir, from Gopinath, sir, you are one step further or one important final solution for improving your ATCOM and communication related things for 2035, sir. Any of your suggestions, please?
The implementation of clerkship, doctor learner method will definitely improve communication and professionalism, sir. The community-based learning has to be given more importance because community problems are different, illnesses is different, seeing the patient in his own place, his economic status, how he behaves when there is an illness, how he manages his family, what is the out-of-pocket expenditure, everything the learner will learn. We conducted a study on grief counseling, sir.
Yes, sir.
It was an interesting study. Actually, it received an award also. Neonatal deaths. After 1 month after death of the baby, after 1 month of the death of the baby, we call the parents and ask them what was the scenario at that time when the baby died. And we are overwhelmed with the response. One mother told, I was left alone to cry.
Yes.
There was no one to touch my shoulder. This was the word she used. So it brought a lot of change in our behavior afterwards. We started we told the assistant professor should break the news and he should be there to spend at least 5 minutes along with the patient. And the PG should definitely accompany. PG
Yes.
and CRMI should see the role modeling being done there. This is happening now after the study. So this is how communication can be improved, sir.
Fantastic.
The community-based setting, manpower, who has to accompany, all these are problem. Probably we can include the PHC medical officers, village health nurses, and the Anganwadi workers to accompany and help.
So they can also be involved. They should also be trained.
manpower can
Absolutely,
be
sir. For want of manpower, definitely we need to train these people also.
Yes, sir. They
Thank
can
you
be
so much, sir. So shifting from bedside to more of community
community
oriented. Thank you so much, sir. One import. Now the question I am posing to the audience for want of time, but just 2 or 3 faculties can give any one single change. என்ன சார் கிருபா சார் தலைவர் கை தூக்குவார்னு கண்டிப்பா தெரியும் தலைவர்கிட்ட மைக் கொடுங்க சார் sir one change that you want to initiate now onwards to have a very good CBME by 2035 at least.
I think one Dr. Anjana said integrated assessment.
Integrated assessment. Yes. Thank you, sir. Thank you so much. Any other faculty, ma'am? Anita, ma'am. இதான் சொல்லுங்க மேம் என் செஷன்ல மட்டும் ஒன்றும் பேச மாட்டீங்க உங்க ஃப்ரெண்ட்
Sir, again, I'm also seconding SAR's statement, integrated assessment.
integrated assessment. Yes.
And formative assessment has to be given more weightage.
Sir, more weightage to be for formative assessment. In addition to it, we should focus on integrated assessment. I think integrated assessment module ஒன்று ப்ரிப்பேர் பண்ணிடலாமா மேடம் அஞ்சனா மேம் ஒரு integrated assessment மாடியூலுக்கு ஒரு இதை ஸ்டார்ட் இனிஷியேட் பண்ணிடுவோமா integrated assessment module which we can initiate. Yes, please, madam.
Sir, my opinion is unless the individual specialties lose their boundaries, this cannot be achieved.
So there should not be any
Yes,
boundaries
sir.
at all. Yes, thank you. Any other suggestions? 1 or 2 suggestions from the audience? Thiruva sir கை தட்டிட்டாரு போதியா நிப்பாட்டியா அப்படிட்டாரு. So I would like to conclude.
Sir, one more.
Yes, sir.
Suggestion. Regarding learner doctor method is not properly followed in many of the places. Learner doctor method should be properly implemented.
உண்மை சார். Thank you. It needs to be properly implemented. Yes. அது implement பண்ணா இன்னும் கொஞ்சம் I think students can learn in a better way. So I would like to conclude my session. சங்கீதா மேம் இங்கிருந்தே எனக்கு கால் பண்றாங்க. So I would like to conclude my session with one important quote, madam. Adoda mudichirren nanu, right? All great changes, as madam said, all great changes are always preceded by chaos. ஒரு chaotic stage இருந்து கொஞ்சம் மூவ் ஆகி definitely we have transformed ourselves. At least இந்த மாதிரி conferences, medical education conferences, we tend to meet together, all faculties, they share we all share our experiences, we all present our papers. What a wonderful presentation the last 2 days we had. ஸோ இதுவே ஒரு பெரிய மூவ்மெண்ட்டாக ஒரு சேஞ்சாக நான் நினைக்கிறேன். ஐ திங்க் தட் இஸ் அ பிக்கஸ்ட் சேஞ்ச். ஸோ இதை விட இன்னும் அடுத்தடுத்த சேஞ்சுக்கு நம்ம போவோம். பை 2035 வில் டெஃபினெட்லி மூவ் அவர் சிபிஎம்இ மாடல் டு த நெக்ஸ்ட் லெவல். 2045 அடுத்து மீட் பண்ணுவோம். தேங்க்யூ ஸோ மச் ஃபார் ஆல் த எக்ஸ்பர்ட்ஸ். தேங்க்யூ ஸோ மச். எனிதிங் எல்ஸ் ஃபைனல் ரவுண்ட் யூ வாண்ட் டு டாக் மேடம்? விட்டுருங்க சார், கிளம்புற அப்படின்னு மேடம். ஐ தேங்க் அவர் சங்கீதா மேடம் ஃபார் கிவிங் மீ திஸ் வண்டர்ஃபுல் ஆப்பர்ச்சுனிட்டி. அண்ட் பிரிசில்லா மேம், தேங்க்யூ மேம்.
Sorry, Dr. Balaji. Actually, I must thank Dr. Balaji, the moderator of the session, and all the panelists for a wonderful discussion. Actually, this is rethinking, revisited the medical education again. We'll do, sir. Okay, this kandipa change erpadthum. The change in the after this conference, during this conference also, I got many applications from my faculties that we want to do ACME. So this is actually a great credit to this conference, I think. Okay. So thank you all for your valuable thoughts and time with us. And sorry, Dr. Balaji again. Balaji coaching matter. Balaji is my junior in UG Salem Medical College. Thank you, sir.